listening to Scoot Closer.
Welcome to episode 4 of Scoot Closer. My name is Shweta.
Hi, I'm Ankita.
The theme of this episode is maternity care access, and what are the contributing factors that can limit it where you live, and what are the consequences to mothers and babies in the areas where they have insufficient care.
We are interviewing Dr. Amanda Williams today. She is a leader in maternal health on the national stage. She currently serves as an advisor to the California Maternal Quality Care Collaborative and has built a career on equitable maternal care. She is fantastic. She's a warrior when it comes to maternal access and maternal care, and we could not be more excited to speak to her.
Yeah, Dr. Williams, she was such a get, and I can't wait for everyone to hear her interview. But a lot of our listeners are probably hearing this phrase for the first time. I know that, Ankita, when you and I were introduced to this topic, when we first met with Dr. Williams, you were like, what is a maternity care desert?
I was like, wait, what do you mean? Why does this matter? Does it happen in deserts everywhere?
Yeah, I mean, and that's maybe listeners should know, we both live in cities and we've always lived in populated suburban or urban areas our lives in the U.S.
I think most of our listeners too, they're probably listening to this as they're walking around in the city, just like extremely accessible to everything. So this is a really novel concept, and you're going to be like, why does this matter? And what's the impact here? But those are some of the questions that we want to dive into with not only Dr. Williams, but, even as we go through some of the statistics and really discuss what the impact is on a community.
Let's go into some definitions. A maternity care desert is defined as a county where there is none or limited access to any maternity care services. So that would include birthing services or obstetric care providers. And they're a lot more common than you think in the US. And you already know the answer to this, but for people listening, just think of a percentage in your head. What percentage do you think in the US is considered a maternity care desert? Hold that number in your head. I'm going to be a magician and tell you what it actually is. It's insane.
I don't think that's called magic.
Okay. So there are mentalists.
Yeah. Still.
I'm trying to be.
You're just stating facts. You're not doing any tricks. Oh boy.
Oh no. Well, I tried, but hold that number in your head. I'm going to shock you because the number I say is not going to be the number you're thinking. And that is my
opposite. You're the opposite of a mentalist. Okay. What is happening?
I'm the opposite of a mentalist.
Oh, God.
Okay. The March of Dimes organization does this annual report card where they assess the state of maternity care deserts in the U.S. And in 2024, they came out in their report with the latest number, and they found that over a third of counties in the United States are considered maternity care deserts, which means that they lack birthing services or obstetric care providers. That's 35% of U.S. counties. That's 1,100 counties in total, where over 5.5 million women reside. And there is not a single birthing facility or obstetric clinician available to people living in those counties. That is insane. Is your mind blown? That's my mentalist service for you today.
I think you should stick to your day job and your side hustle of the podcast.
That's fine. No more hustles than this side hustle. I think we could easily brush past this stat, but this country is supposed to be world leading in most things, allegedly. But what we're saying is that as a global leader, 35% of the counties in this country literally don't have medical services available for people giving birth.
Yep.
What the hell?
The US is no longer leading in a lot of these numbers. And I think that It feels scary. And you and I kind of joked about this the other day where we were like, we've seen the rise and the fall of this great nation, because it literally feels like in the 90s and the 2000s, all of this fantastic things that were coming out of America. And it still is. But over the years, we have started to see that America lands lower in education, lower in healthcare, lower in healthcare access, lower in affordability, lower in happiness. And so this number, as shocking as it is, should it shock us? Because we are cutting access all across the board.
This is basically the part of the episode where listeners are like, okay, now we're in a downward spiral. I'm going to turn the episode off. But we promise we're here to not only despair, but we are going to talk to Dr. Williams. We are going to learn about the things that are happening to make this better. But we need to understand the problem. So yeah, Ankita's right. Like, shit's bad, you guys. We're not investing in health the way that we should be, and health services. And Ankita, I think you're going to tell us a little bit more about how this problem is actually increasing.
Exactly. So since 2020, the deserts have increased by 4% nationwide. And this number is just going to continue to rise because many rural hospitals are funded by Medicaid. And these rural hospitals, they depend heavily on Medicaid revenue and funding, and they're already operating at negative margins. So in 2023, 48% of rural hospitals were operating at a loss. Now
that's
imagine,
wild. That's half.
That's
half of the rural hospitals in the country were just totally operating at a loss. So of course they're going to cut the things that have complex costs.
Exactly. And Dr. Williams talks about this in her interview, where she explains why OBGYN services are some of the first ones to get cut, because they have the lowest margins within the hospital. And that's just really scary. So already 48% of rural hospitals are operating at a loss. And now they are all probably at risk to get their OBGYN departments cut. So we're increasing the maternity care desert as we speak. And guess what?
I have a feeling. I know. You know what? This is another mentalist trick. I'm going to hold the answer in my head. Actually, never mind. I know what the answer is.
Yeah, exactly. So on July 4th, Republicans signed into law the big, beautiful bill. And what it did was it slashed $1 trillion in Medicaid spending over the next 10 years. And there was an analysis done by KFF, an independent health policy and research news report. And it estimates that rural areas could see their funding reduction by $137 billion in Medicaid over the next 10 years. That is directly putting rural hospitals in the path of destruction in front of this big, beautiful bill that we have. And I just want to take a second and just have a bit of a rant right now, and nothing that I'm saying is like brand new information, but there's profit and then there's betterment of the greater good. And to me, it feels like as a country, we have lost the plot. We have to find a way to not be binary about this and to have some middle ground. And I believe that this is where government comes in. Businesses are supposed to be businesses, and they are meant to be run for profit. But the government, they have to step in and they have to help out with the greater good. And I don't see that happening right now. I don't see the government looking after the good of the people. The government is looking after
businesses.
I mean, clearly, this is not new information for anyone. They're looking after a certain group of people, and it's very business focused, and the government is being run like a business, and I don't believe that it should be. When I see impact like this to entire communities, to 35% of counties in the US, I've lost the plot. I don't understand how we got here. Not providing access to people is how we get to a better dollar sign. Please spare me.
It's an impossible pill to swallow to hear that we are accepting mortal outcomes
Yes.
because of the bottom line. We're saying the economics don't work for these hospitals in rural areas to provide birthing services. So we're okay that might mean negative outcomes for mothers and babies. That's fine, because at the end of the day, it didn't put money in our pockets. But like Ankita said, businesses are going to do what they do. And there is a role that our other institutions should be playing to balance that out. And they're not playing it. And that is where we are today with the funding cuts that we're seeing and kind of the cliff that we're on when it comes to what's about to happen to care deserts. The reason we picked maternity care deserts for this episode is because there are infrastructural challenges, there are systemic challenges to why we see our science fall behind, or our research fall behind, or our treatments fall behind and be insufficient. We have terrible health outcomes for people, and we don't have data and information on how to support them. And we're looking at the data from the March of Dimes report that people who live in maternity care deserts have disproportionate health outcomes. So women that are living in those care deserts are 3 times more likely to die from a pregnancy-related cause, and the risk of preterm labor for them increases by 13% in these counties.
Yeah, because they're probably not getting the care at the right time in their pregnancy journeys, because again, the access is farther away. Probably a lot of these places are slammed. And so, you can't actually see your providers as frequently as you need to. I mean, high risk pregnancies, sometimes you're seeing them weekly. Sometimes you're seeing them multiple times a week. So if you're dealing with something like that and you don't have access, then it's no surprise that mortality would rise in those cases.
Anecdotally or intuitively, many of us probably understand that racial bias in our health can also lead to disparate outcomes between races. And what the March of Dimes report found is that preterm birth rates are higher across every race that is in a care desert. So whether you are white, Black, Indigenous, Hispanic, Asian, whatever, you are at a higher risk of preterm birth if you live in a care desert. However, people who are in the Black and Indigenous population already experience higher rates of preterm births compared to other races. And so imagine if you are already, for reasons that are systemic, now it's compounded, right? So now if you are in that demographic and you live in a maternity care desert, your preterm rates, your maternal mortality rates get worse and more challenging. It is important for us to talk about the fact that there are socioeconomic implications to this and there are racial implications to this. And I think both of those factors are really important for when we consider populations that are living in care deserts. We know our own families that having access on time during critical moments has been life-changing for us. And Ankita, you and I don't live in a maternity care desert, but if we had, your outcomes, I think, in your pregnancies would have been vastly different. And your third pregnancy really comes to mind for me as I was doing this research because of the amount of women in maternity care deserts who often deal with preeclampsia and the immense challenges that they go through in getting timely care. I don't know if you want to talk about that.
Yeah, I do. I think one thing that as we were prepping for this that kind of stood out to me was I feel like I'm sharing a story with each one of our episodes. And I wonder if our listeners are like, what is wrong with this girl?
They're like, how many babies has she had? How many pregnancies?
Not only that, but they're like, how could so many things go wrong all the time? And listen, dude, I think the same thing every time we recap one of these things. I'm like, how did all of this stuff happen? And I'm thankful that I'm here to still talk about this, but it really feels overwhelming sometimes to look at all of the health journeys, as a whole. But anyways, so during my third pregnancy, I presented with preeclampsia postpartum, which is pretty rare. If you do have preeclampsia,
You're like a modern medical marvel.
No, listen, I just like this is I've been on the wrong side of statistics for everything, and I just like I can't.
How often will someone
anymore.
say like this is pretty rare? And actually, I wonder how many listeners hear that and they're like, get real. Okay, just a total aside, irrelevant. I was Googling today what's like the average amount of blood somebody's supposed to lose during their period. Do you want to guess?
Like during the whole, like how many ever days?
Yeah.
Like 3 cups to 4 cups worth. What?
Dude, okay, so you know what the internet said? That if you're losing more than 2 ounces of blood during your period, then you have a health issue. Yeah, and I said that number to my girlfriends and we all laughed because I bleed 2 ounces when I sneeze during my period.
No, 100%. 100%. I laughed too hard the other day and I was like, I got to stand up.
That was my whole period.
Yeah. Yeah. Are you kidding me? 2 ounces? There's no way. There's no way that that's real.
So all I'm saying is that when people say like, this is what normal is, and now this makes you a very rare stat when it comes to women's health. And it's like, I don't know, how many women have you actually talked to when you created the baseline? Because everyone I'm talking to thinks that's a joke, but I digress.
Yeah, seriously. Yeah, no, that's actually crazy. During my 3rd pregnancy, I presented with preeclampsia postpartum, so after giving birth. Most people, when they present with preeclampsia, it happens usually, I think it's like around the 35, 36 week mark is when, people see it. And that usually coincides with like a checkup that they've had. So again, if you're in a maternal care desert and you, for some reason, decide not to go in for your 36 week appointment, you could miss it. And then you could, be giving birth and then have to deal with all these other complications. Anyways, there's just a reason why the checkpoints have been set up the way that they have in pregnancy. And I can imagine that, you end up missing some of them if you are in a care desert.
And just to let our listeners know, preeclampsia is kind of an unknown condition in terms of what the cause is, but one of the main markers is high blood pressure. And I think there's a ton of different adverse outcomes with preeclampsia, but one of the main ones is it could lead to seizures if left untreated.
And actually, I've heard new research coming out that points to preeclampsia coming from the placenta, and now we know that placental health is determined by the sperm. So pick your partners wisely. That's all I have to tell you. But anyways,
sperm carriers, you better.
We're coming for you.
Just I know we're coming for you. We're gonna do an episode all about you.
So basically, it was interestingly enough the night before we had rushed to the ER because my son was not breathing correctly. So we had actually rushed to a children's hospital. We'd made sure he was okay. We'd come back home, and I woke up the next morning just like wheezing. And I was like, oh, that's weird. I feel like I have a cough or something. And as I'm showering, I can hear crackling in my lungs. Like, I'm not even kidding you. I like took a deep breath and I could like hear the crackle. And I called my husband over and I was like, listen to me breathe. And he's like, that's weird. I heard that. It sounds like pop rocks. And I was like, okay, something's up. And we immediately text my doctor. She says, check your blood pressure. It's high. We rush to the hospital. I get admitted. Now I'm in the hospital for, I think it was like 3 or 4 days on meds. I had my newborn by my side. My toddler was at home, and I had family that was taking care of all of the things, and they were bringing my toddler over to see me just so that I could see her every day, and all of these things.
Who's they?
Yeah. You.
The hell?
I forgot.
You forgot?
Dude, I don't remember anything about these time periods. That was a traumatic ass week. It was.
You know what? I'm grateful that somebody could block it out of their head. The
If
rest
you
of
ask
us
me about,
did
you
not.
know, these time periods of my
I
life,
know.
they're really like blank spots.
Maybe it's for the better.
But remember the hospital food?
I was going to mention that. I have to pause to say, like, very, very scary for Ankita to give birth and then, like, have to go to the hospital so soon after with a newborn, because you're like, you don't want to bring him back into the hospital. And, like, now what's happening with everybody? It's really uncertain. But the look on her face when she realized that she could order a veggie omelet from the hospital, which is, like, her and Neelam's favorite dish.
It was like the veggie omelet, and I think they're grilled cheese.
Yeah.
Oh, to die. It was probably not helping my blood pressure, if I'm going to be
No,
honest.
of course not. But were they doing it? Yeah. These
My
every single
doctor
day.
said I could. But anyways, rushed to the hospital, was in a hospital for a few days postpartum, and I can't imagine doing any of that, being in a maternity care desert, because the access for my family to be able to come and see me would have been so much more difficult. And that's what stood out, is that we could have had a really poor outcome if we didn't have access to medical attention as immediately as we did. And the story didn't just end there. I ended up back home, obviously, a few days later, but there were still a couple of scary spots where I still needed medical attention. And so I would have to just hop back into the hospital.
Like middle of the night.
Sometimes
Yeah.
middle of the night. And that continued for, I want to say, like 2 weeks. And again, my hospital is 6 miles from my home, and that still felt too far of like,
Yeah.
oh my God, what are we doing? And I just can't imagine being in these counties where care is just farther and farther away.
I mean, I'm grateful, and I think we both are, at how accessible care has been for you and for us during these times. When we were researching this episode, I wanted to listen and hear more stories of women that were being impacted by maternity care deserts. And there's probably a large portion of Native land and Indigenous communities that are impacted, and not surprising. I had a really hard time finding anecdotal stories about people in the Indigenous community because it's so underreported. I did come across a lot of stories of so many women were interviewed saying that they assumed that they were going to end up giving birth in their car. We're just so tired of driving to their appointments 2 hours on the road one way. And there were just so many scenarios where maybe it's not even their first kid. So now they have the added logistics of carting around all their kids while being pregnant, or figuring out where to leave their kids while they're gone for hours for their checkup. Absolute travesty. But I think it's important to remember, I know the stats are dark, that it feels like we are just spiraling down. We just want to be really clear-eyed about the problem, because this is a challenge in front of us. The really exciting thing about talking to experts and learning about this issue is that there are always badass people who are doing something to make it better. And you're about to hear our interview with Dr. Williams, who has been at the forefront of efforts to make pregnancy and childbirth safer and more equitable across the U.S., to create more opportunities for access for people that live in deserts, and more creative solutions that don't only rely on archaic systems that are expensive. So stay tuned. Welcome, Dr. Williams, to Scoot Closer. For those that are listening, Dr. Williams is an OBGYN and a nationally recognized leader in maternal health. Dr. Williams previously served as the medical director for pregnancy at Kaiser Permanente, the medical director at Mommy, a health tech company, the interim chief medical officer at March of Dimes, and now currently serves as an advisor at the California Maternal Quality Care Collaborative. So if it sounds like I'm introducing 4 different people, I'm not. I'm just introducing one guest who has worked on this issue from a 360 perspective. And we are so excited to have you on the show and to learn from you. So thank you for joining.
Thank you so much for having me. It's always fun to talk about my favorite subject.
Well, Ankita and I have been learning a lot more about maternal care deserts since speaking to you early on. What does it mean to actually live in a care desert? And what do you think are the contributing factors that predict or characterize a maternal care desert?
So, maternity care desert is a county that has no obstetric provider. So that means no midwife, no family practice doc who does obstetrics, no OBGYN, and no place to have your baby, no labor and delivery unit, and no licensed birth center. I think that people are stunned to find out that 35% of all counties are actual maternity care deserts. Nobody with advanced training to deliver your baby, and no place that is exclusively for delivery of babies.
Over a third of the US. I just am stunned by that.
I don't think a young couple goes and buys a house in a nice neighborhood and they might say, oh, the school system's good, but are they actually looking at the hospitals? And so that's one of my community takeaways is if you are in the family building phase of life, look at what the healthcare is for moms and babies in the place where you're thinking about moving. Because if you live in a maternity care desert, you are more likely to have inadequate prenatal care. You are more likely to have a preterm birth. So it has actual real consequences.
That sounds scary. As somebody who's had pre and post baby complications, and just as somebody who's been at the doctor so frequently during this phase of my life, I can't imagine what limited access would look like if you're dealing with a complicated situation, whether it's pre or post-term.
I was a maternal mortality review committee member for the state of California, and we looked at every death that happened to a woman in the state of California during pregnancy or in the year postpartum, and to try to learn, figure out what systems changes can be made, etc. And by the time I was about 20 cases in, I could just look at the geography. I could look at where the woman lived, and I knew she had no chance. That's depressing. We live in the United States of America. It's supposed to be so much better than that. And it's just not the reality for so many.
Can you walk us through the impact, short-term, long-term, when a community loses its maternity care services?
Yeah, so between 2020 and 2022, over 100 hospitals closed their obstetric units across the United States. So that is 1 in 25 hospitals in the United States closed their obstetric units between 2020
and do we know
and 2022.
Do we know why?
Yeah, there are myriad reasons why, and part of it is because doing obstetrics is hard. You have to staff your hospital at a high level 24/7. Babies don't just come between 9 and 5. They come any time of the day or night. You also have to staff it as triage, so an area for assessment, so kind of like an emergency room. You have to staff it like an operating room because people may end up with a C-section. And then you have to staff it like a labor and delivery birth center where they could have their vaginal birth. So you've got to have really complex staffing 24. Then from a reimbursement standpoint, over 40% of the births in the United States are insured through Medicaid. And Medicaid, almost everywhere, has a lower reimbursement for the hospital, for the clinicians, than commercial insurance. And so you have razor thin margins when it comes to profitability around reimbursements for them. And then we have birth volumes going down. We know in the United States, birth rates are going down. And we know that volume helps drive competency. It is not the only way to get to highly competent care, but if you only do something once a year as opposed to once a week, people start losing their skills when volumes go really low. So it's a heartbreaking decision for a hospital to close its labor and delivery units, but in general, they're seen as loss leaders. Almost no hospital is really profitable around labor and delivery. They hope to break even, but it is very expensive to keep labor and delivery units open.
So it kind of just sounds like capitalism is at the root of this. We have razor
that's a
margins.
That's a whole nother interview.
I know, but it just sounds like it's razor thin. Yeah, it's razor thin margins, it's insurance, and then people are having less babies because the cost of living is astronomical across the board. And so, yeah, okay, capitalism, got it.
Exactly. And then if you double down on the cuts to Medicaid that were recently passed, it is going to get worse. The thing that's worse is having no insurance at all. And just because someone loses their Medicaid doesn't mean that they're going to just get zero care. It means they're going to come in more sick, with nobody to bill for the care that they require when they come in and deliver in the emergency room or at the side of the road, and then have huge expenses.
It's really interesting to hear how you lay out the challenges. But yeah, as people that are prospective patients, it's like painful to hear, because we're basically saying like, the economics are tough because you're sicker and you need help. So like it actually makes it harder for us to help. Like from a hospital system standpoint, I think that's a hard thing to hear.
It is a hard thing to hear. And there are things that people can do. There are things that they're sort of societal solutions. There are individual solutions. So I don't want your listeners to feel disempowered, because there are things you can do. But the first step is just the knowledge, is just knowing that this is an issue and finding out what are the obstetric services in your community. And if you're planning a move, starting a family, etc., starting a new job, you want to ask these questions as you're going into it. People make the assumption that there's good care, and that's not necessarily true.
I definitely want to get into what are the things that we're excited about in this space. I want to make sure, though, that we do define those consequences that we talked about for care deserts. So what happens in a community that's losing its care services? Are there particular populations that are impacted?
Yeah, it is devastating for a community to lose its labor and delivery unit. First of all, it's a source of jobs in a community. And those employees then use the services in the area. There's that economic piece of it. Then there are the consequences for the individual patient and her family. So people who live in maternity care deserts have to travel 2.6 times longer to get to the hospital. So when it comes to where these care deserts are, the majority are in rural communities. We also see the indigenous communities being disproportionately impacted, and then communities of color such as Black and Latinx, a little bit behind indigenous, but also having disproportionate impact of hospital closures. So what we see is a layering on of marginalization. We have communities that our society has already marginalized, and then now we have care being taken away on top of it. So this is what we call inherited disadvantage. It's not like there's something wrong with Indigenous people having birth. It's that there is accumulated inherited disadvantage that is the consequence of this layering on of marginalization.
Haven't heard that phrase before, but I feel like it captures it so well, the compounding of all of these different obstacles.
And again, this is not to say that there is not hope. There are real solutions. There's expansion of midwifery training. There is expansion of community health worker and doula training. We can have policy solutions around maintaining Medicaid, around maintaining reimbursements. You can get high-risk consultations done in a video appointment. For certain patient populations, doing virtual care is just as good, not for every visit, but for a mix of the visits, as doing in-person care. Then there are there's mobile care. So when I was at March of Dimes, we really were lifting up our mobile care buses that were going out into communities that were underserved and bringing the care to the people. So you can either bring the people to the care, or the care to the people. So all of these things are possible, but will we have the political will to actually act on it?
Yeah. That's a whole nother episode too.
Yeah, totally. And like you said, the first part is just acknowledging who it's impacting and how pervasive the problem is.
We also, especially with cuts to Medicaid, are going to see even worse prenatal and postpartum care for patients because there's going to be less reimbursement. If somebody has, God forbid, gestational diabetes, or they have twins, they now need to see a perinatologist or ultra high risk doctor. And if that's 2 hours away, there are a lot of patients who will just skip that care and then not get the support that they need.
As somebody who was seeing MFM for my pregnancies, there were times towards the end of one of my pregnancies, I was going multiple times a week because we were doing like I can't remember now what it's called, but the heart rate check.
Yeah, the non-stress testing. So you're talking
Yeah.
MFM stands for maternal fetal medicine. Another word for perinatologists, which are this sort of ultra high risk obstetricians. And as you said, people who are having very high risk pregnancies can be going in once or twice a week.
How often in care deserts are we even catching a high risk pregnancy?
Exactly. So we're gonna underdiagnose and then be able to under support. I mean, there's so many people who this lack of access to care impacts.
We were saying earlier, like we were looking at all of your work experience and can see that you've worked in so many different types of places, whether they're large health systems or nonprofits or even startups. And I'm curious what each of those have actually taught you about moving the needle for care access, what you think is having an impact.
I am first and foremost an OBGYN and will always put patients in the center. And I know that none of those approaches, whether it's the startup world, the nonprofit world, traditional healthcare systems, none of them can function alone to be everything to a patient. The most important piece that I've learned is that there has got to be sharing of responsibility to wrap around this pregnancy journey. None of these entities are good at playing with others. So I like to think of myself as a bridge builder and try to think about what does a greatest hits album look like for perinatal care. For example, something like perinatal mental health. We know that suicide and overdoses are leading causes of maternal mortality. And many times there are opportunities for intervention. In your prenatal care, you may or may not be screened for depression and anxiety. You may or may not have your social needs assessed, like your transportation, your housing, or your food. And so over the course of that pregnancy, if the patient is not in touch with their community-based organizations or with any type of social services needs, that may be tabled and it might make her depression worse. Not to mention the fact that the mental health department could be an entirely different building across town with a different referral, and then someone doesn't take the appointment because the patient has Medicaid. I mean, it's all so fragmented. And that's where I think we have the greatest opportunity, is to bring traditional healthcare, startup world, public health, and communities together to think about how can we wrap around the patient.
Have there been more local success stories, maybe at certain hospitals or towns that you've seen where these systems are working well together?
One of the privileges of my work at Stanford and CMQCC is that we work across the state of California, all 209 hospitals with maternity units, and we're trying to help them build those relationships and collaboration with their public health departments. One of the areas where I see really innovative work going on is in Fresno County in the Central Valley in California, which is a rural area, yet they have very engaged obstetricians. They've got a couple of really good higher volume maternity hospitals that work with community doulas and community health workers to be able to provide support for patients in a way that really is inspiring. And they actually do case conferences, do sharing.
You know, it's Not often that Fresno gets a shout out, so happy for them. It's exciting to no hate towards Fresno. It's
No,
just
that's
it's
why
great
I
to hear
try
that.
it, Central Valley.
Lift them up.
There are good things happening in the Central Valley. It is where the highest
Yeah.
maternal mortality rates are in the state of California. But
wow.
California has the lowest maternal mortality in the whole country. So this kind of collaboration is what has the potential to save lives.
As you were kind of chatting about our villages and our communities, it just seems like over time, our villages and our communities have gotten smaller, and we're seeing that in the way that women's healthcare is provided. We have this theme where we talk a lot about continuing to advocate for ourselves. One of the resources that I had, and I would encourage listeners to look into this once you enter that life phase, a lot of great companies provide things like carrot support, which allows you to have support maybe postpartum. So I was able to use postpartum services and get night nurses, but those funds could have been put towards doula care and all of these different things. So I would encourage people to kind of look at their benefits, because you're right, like care is shrinking, but maybe you work for a company that is allowing, sort of this like outside access.
And take advantage of, if you have a health savings account, is another way to do it. So some people have these support benefits, whether it's your fertility benefit, lactation benefit, some of these different maternal health startups that give virtual doulas or therapists support. There are lots of ways to try to access it. In California, there actually is coverage for doulas, both for commercial insurance and for Medicaid, which is pretty extraordinary. There's only a few states that have it, but wrapping yourself in support is so essential.
Do you have any other advice for our listeners? Any other benefits or any other advocacy or support that you would encourage them to search out?
Everybody can benefit from a doula. I was board certified practicing obstetrician, having my second baby, and I still had a doula because I wanted the individualized support. I wanted a safe place to be able to just unload and be a mom and not have to be Dr. Williams. The other thing is looking out for midwifery care. If you are a low-risk pregnancy, let the experts in low risk take care of low-risk patients. Physiologic birth does happen. Not everyone is high risk. And the best scenarios is when midwives have good partnerships with local OB. That is a huge difference between the United States and almost any other of our economic peer countries, is overutilization of obstetricians that are going down, particularly in rural areas, when midwives provide amazing patient-centered support. Another option for care is group care, whether it's the official sort of centering prenatal care approach or other group care approaches, can be incredibly helpful, especially for patients that have a commonality, so like teen mothers or mothers with gestational diabetes, so that they can really rally around each other and get that community support and get wisdom and ideas from each other. Attending to your mental health is incredibly important. Trying to get your mental health support set up from the get-go is really key. And we know that there's going to be a huge hormonal shift that happens in the postpartum side of things. So make your appointments. And it's so much easier to cancel appointment than to get an appointment. So while you're still pregnant, make yourself an appointment a couple weeks after your due date so that it's there and in place in case things don't go as well.
Speaking of group care, my mom's group chat is lit. And it's filled with breastfeeding advice and, behavioral things. It's such an important sort of marker for us of like, does this make sense? Like, is this normal? We have kids, sort of all ages, but in similar ranges. And I think from the very beginning, when we all started getting pregnant to when we had our babies, that's always just been such an important part of our lives. And a gut check of, is this okay? +1 to group care.
Yeah, and to having just community. Live, the US culture is so sort of individualistic. Like it comes from this mindset that like you're supposed to be this like hardy cowboy pulling up by your bootstraps and doing everything yourself. Rugged individualism. Like that is just, it's first of all, it's not even reality for American history, and it's actually harmful to people growing families. I think there's a good chunk of postpartum mood disorders that comes from isolation, and it really is helpful to have community when you're in this family expansion life phase.
I love this call out, whether you're living in a care desert or not. I think that's just one of the most critical parts of the experience. Dr. Williams, thank you so much for joining Scoot Closer. We're so grateful for the wealth of knowledge that you gave to us today and for sharing your stories. We learned a lot about this topic.
Well, thank you. Thank you for creating this space and educating community and encouraging people to empower themselves, because no one's gonna, unfortunately, do it for them. I will keep trying to get doctors and nurses to act right. In the meantime, we're all going to inspire and encourage our patients to load up with information and to lean on each other during this time of transition.
Thanks everyone for listening, and if you've made it this far, here is our call to action. The number of U.S. counties designated as maternal care deserts is rising, and your access could be at risk. We encourage you to vote in your local elections, ask your representatives what they're doing to support maternal health, and push for policies that prioritize access and equity. Dr. Williams said it best during the episode. If you are low risk and hospital care is out of reach, consider midwifery and doula support instead. Proactively schedule your mental health check-ins and find and build your village. Whether you're navigating gestational diabetes, high-risk pregnancies, or postpartum challenges, connecting with others in similar situations can be a powerful source of wisdom, solidarity, and support. If you need help navigating any of this, feel free to email us at hello@scootcloser.com or check out scootcloser.com, our website, for additional resources.